Good afternoon, everyone, and thank you for participating in today's Region 7 Disaster Health Response Ecosystem Preparedness webinar series. Today, we're going to discuss the medical management of chemical exposures with Kathy Jacobitz and Dr. Bryan Wilson. A few housekeeping things before we get started. Audience objectives and description are here on the screen. Continuing education, today's webinar is accredited for 1 continuing education hour for physicians, nurses, and EMS providers. We have no disclosures. Our planning committee, Dr. James Lawler, does have a disclosure which is listed here on the screen. For today's Zoom webinar, we do have a few minutes allotted at the end to go ahead and take questions and answers. We ask that you please put your questions into the Q&A function on Zoom, which you can see on your Zoom controls. At the conclusion of the webinar, you will be able to obtain your CE credit. If you go to the go.unmc.edu and then type in the code seen here, and we'll provide this again at the end, you'll be able to claim your credit. And then with that, as they begin to share their screen here, I'll go ahead and introduce our presenters. We have Kathy Jacobitz, who Kathy is the director of the Nebraska Regional Poison Center in Omaha, Nebraska. She's a nurse certified specialist in poison information with 38 years of experience in the field of clinical toxicology. Kathy also serves in National Poison Center leadership roles and has presented and published several toxicology research studies. She's actively involved in local, state, and national disaster preparedness initiatives. And then we have Dr. Wilson, who is an emergency medicine physician and practicing medical toxicologist at the University of Iowa Hospitals and Clinics in Iowa City, Iowa. He completed a combined residency in emergency medicine and pediatrics, as well as a fellowship in medical toxicology at the University of Arizona in Tucson, Arizona. He's board certified in emergency medicine, pediatrics, and medical toxicology. And with that, I'll turn it over.
All right. Hi, everyone. I appreciate you tuning in to hear us talk today. I appreciate the opportunity to speak to you about this topic. Kathy and I are both very excited about it. As a kind of overview of the format of the talk today, I'm going to spend about the first half of the talk just giving an overview of some of the common categories of chemical exposures, how they present, and the signs and symptoms and treatment of those exposures. And kind of the idea is to help emphasize why this topic is important, how we might see mass casualty events with these chemicals. And then we'll turn it over to Kathy, and she'll talk a bit about the chemical specialty team and the resources that are available to help you manage these patients. In terms of our objectives, we're going to describe the toxicity and treatment of selected chemical exposures, namely nerve agents, cyanide, and irritant gases. We're going to discuss the roles and responsibilities within the R7DHRE Chemical Specialty Team in the medical management of chemical and other hazardous materials incidents. And then we're going to identify evidence-based chemical exposure management resources available to you all. So with that, we'll kind of jump into our first big category, which is going to be irritant gases. And I've included a couple of examples here. So ammonia is a common household cleaning agent that we're probably all familiar with. It's also used in industry for a wide variety of synthetic and other industrial purposes. Similarly, we have hydrochloric acid and chlorine, which we may see out in the community used as pool cleaning agents and pool maintenance agents. And then again, very common out in the industrial setting. Switching gears a bit, we have phosgene as another example. So this was a chemical warfare agent used during the First World War. And likely large stockpiles still exist, though theoretically we are dismantling them. And then something that's been in the news recently is nitrogen dioxide, which has come up with the idea of gas stoves. And any sort of incomplete combustion can lead to nitrogen dioxide, even exhaust from our vehicles. Typically, we consider it more of a chronic exposure concern, but you can have larger exposures related to industrial settings where it's used for creating fertilizers, and also historically was of concern because it was a major component when you were of the breakdown of X-rays when they were being burned. And so you can see that there's a wide number of irritant gases that we have in our homes, that we have in our industrial settings, that we have in our workplaces. Also of note, a lot of the concern for mixing household cleaning products comes from the generation of irritant gases like chloramines or chlorine gas. In terms of mechanism of action, they all work pretty similarly. The specific chemistry will vary based on the agent we're talking about, but they all essentially cause local caustic injury after they go into solution. So they go into solution and either the parent compound or a compound generated when it reacts with water will cause an acidic or alkali injury to tissues or some other direct tissue injury. And so we divide the irritant gases into two major categories. We talk about the highly soluble gases and we talk about the poorly soluble gases because of the presentation of these two categories is slightly different. Highly soluble gases are going to stick to the first area of moisture that they come into contact with. And so we see a lot more upper airway symptoms with the highly soluble gases. These would be things like ammonia, chlorine, chloramine. And so we get a lot more upper airway, rhinorrhea, conjunctivitis, oropharyngeal swelling and irritation. And one of the kind of corollaries of this is these gases tend to have good warning properties. So you tend to know if you're in chlorine gas or you're in chloramine gas or exposed to ammonia because your eyes burn, your airway burns. You notice it pretty quickly and ideally can extricate yourself. Contrasting this is the poorly soluble gases, phosgene or nitrogen dioxide being great examples. These need more time to go into solution, so they're able to make their way lower into the airways. We see a lot more pulmonary effects with these typically. And then because they don't irritate the mucous membranes of the eyes, the oropharynx, they take longer to kick in. They don't have that same warning property. And so exposures tend to be a little bit more prolonged as people don't realize they're being exposed. And so ultimately the clinical presentation is anywhere from some upper airway irritation to reactive airway disease to full-blown acute respiratory distress syndrome. Treatment for these patients. So our first treatment is going to be decontamination. One of my mentors always says you want to remove the patient from the poison and the poison from the patient. I think that's a great way of summarizing it. So we want to remove the patient from the scene, and then we want to do what we can to remove any persistent contaminant from the patient. The good news about the irritant gases is because they're usually gases or vapors, often the patient doesn't need too much decontamination apart from just removing them from the source. It's probably generally reasonable to go ahead and remove their clothing, get them into a clean hospital gown as you're able to. But often these patients won't need the full shower decontamination, which streamlines the process for us a little bit. Once we've decontaminated them, main treatment for irritant gases is going to be oxygen and ventilatory support. So we're going to want to help them if they're becoming hypoxic. We're going to potentially need to intubate them and even put them on some mechanical ventilation. But really just addressing the hypoxia as we would with any other respiratory pathology is going to be the main intervention for these patients. If we see signs of reactive airway disease, we hear some wheezing, we hear a prolonged expiratory phase, and we can consider bronchodilators in these patients. And steroids are probably also a reasonable intervention. One other treatment that will occasionally come up with these patients is using nebulized sodium bicarbonate, particularly for chlorine gas. The idea being to neutralize the acid that's being formed as the chlorine gas goes into solution within the airways. There's not as much evidence to validate that, but there probably isn't much of a downside, and so it's a reasonable intervention. That might be one worth discussing with your local resources, such as your poison center or your toxicologist. All right, shifting gears a little bit, the next major category we wanted to talk about was nerve agents. And so there's really two main families that we're looking at when we're talking about nerve agent exposures. One is insecticides, and that's both the carbamate and the organophosphate insecticides. And then also we're worried about chemical warfare agents. And so we can certainly imagine most of us being in the Midwest and having a large agricultural industry around us, how patients might be exposed to insecticides through industrial mishaps or agricultural mishaps. But we're also seeing the chemical warfare agents continuously pop up in the news throughout the last decade. So some recent examples in the news would be the use of sarin gas in Syria, and I believe it was 2013. And also we saw the assassination of Kim Jong-nam in Asia recently with VX used as the assassination tool. And in Salisbury, England, we saw an assassination attempt on two on a former Russian operative, also again using a chemical warfare agent. And so we're seeing it kind of make its way out into use both as part of assassination attempts, as part of chemical warfare. And there have been a number of terrorist attempts using nerve agents, probably most notably the sarin gas attack in Tokyo a number of years ago. And so the point being that this is out there. It is something that we can see either from an industrial exposure or from intentional exposures by malicious actors. And so it's one for us to be familiar with. As a review of the mechanism of action of these nerve agents, so normally our nerves release acetylcholine from a presynaptic nerve. It goes into the synapse where it interacts with an acetylcholine receptor, and that causes a postsynaptic nerve to depolarize and kind of carry on with its action. And the synapse is usually cleaned up through this acetylcholinesterase enzyme that chews apart these acetylcholine molecules, breaks them down into choline and acetate, and then the choline is recycled. And so we get this cycle of release of acetylcholine, activation of the nerve, breakdown of the acetylcholine, and then recycling that allows us to turn on and off nerves. The problem with these nerve agents is they block this acetylcholinesterase enzyme, and that allows acetylcholine to build up within the synapse and continuously trigger the acetylcholine receptor. And so we get this unchecked neurologic activity. And if we look at where in our body we have these acetylcholine receptors, they're really pretty diffusely spread. We have them in our central nervous system. We have them in our autonomic nervous system. We have them in our somatic nervous system. And so if you imagine acetylcholine building up in all of these synapses because we're no longer chewing it apart, you can see how in the CNS, we would get altered mental status, we would get seizures, and the autonomic nervous system, we would get both parasympathetic and sympathetic activation. And then in the somatic nervous system, we would get sort of unregulated skeletal muscle activity, very similar to succinylcholine in some respects. And so clinically, how this all presents, we can divide it into our muscarinic symptoms and our nicotinic symptoms. Our muscarinic symptoms is our parasympathetic system. And so we're going to see defecation, urination, meiosis, bradycardia, bronchorrhea, bronchospasm, emesis, lacrimation, salivation, sweating. Basically our dumbbells mnemonic with an emphasis on the killer bees, the bradycardia, bronchorrhea, bronchospasm that tend to kill these patients. The way I think of it is essentially the killer bees, and then anything that can secrete fluid is going to secrete fluid. They're going to be tearing, drooling, sweating. They're going to experience diarrhea and urination. And then at the same time, we have these almost conflicting nicotinic symptoms from our sympathetic nervous system and from our neuromuscular junctions, where we can also see some mydriasis, tachycardia, some weakness and twitching, hypertension, fasciculations. The memory aid for the nicotinic symptoms is Monday, Tuesday, Wednesday, Thursday, Friday. The idea being if you're a smoker, if you use nicotine, you're going to use it every day of the week. And so clinically tying this all together, what we will often see is initially some of the nicotinic symptoms, and then quickly the patients will be in severe exposures overcome by the more muscarinic symptoms. So they'll be altered, potentially having seizures, and then having these secretions, this bradycardia, this bronchorrhea, and this bronchospasm. And so that will inform a bit how we're going to treat these patients. So again, our first step is going to be decontamination. Again, removing the patient from the poison and the poison from the patient. Typically, these nerve agents, whether they're insecticides, they're chemical warfare agents, they're going to be suspended in a hydrocarbon solution. They're going to be a lot more kind of persistent and viscous and oily. And so these patients often will need some sort of formal decontamination, or typically will need formal decontamination. Ideally, we're going to do that with soap and water after we've removed their clothing. But if you don't have soap and water, there's no need to delay. Just use water, use what you can. And depending on your setting, you may have access to this reactive skin decontamination lotion. So this is another alternative for decontamination, mostly kind of intended for a field or mass casualty setting, where these they come in little packets, and you pull out a little towelette that's been soaked in this lotion that reacts with many of these chemical warfare agents and deactivates them. So just something to know exists and may be available to you. Once we've decontaminated a patient, another concern is going to be applying atropine. And so atropine is being used to counteract those muscarinic symptoms, most notably the killer bees. So we're going to want to titrate the atropine to their bradycardia has resolved, to their secretions in their pulmonary secretions have resolved, into their bronchospasm has resolved. And typically we're going to need pretty large doses. It's reasonable to start at a 2 milligram IV dose and repeat that every 2 to 5 minutes. But some authors will advocate for escalating that dose. And if your 2 milligrams doesn't work, then try 4 milligrams. And if that hasn't worked at 2 to 5 minutes, then go up to 8 milligrams. Often these patients will use many dozens of milligrams of atropine and can quickly exhaust supplies of kind of what hospitals are normally stocking. And Kathy will talk a bit about the Chempacks and that as a resource for larger aliquots of atropine. But just be aware that these patients will probably need more than the 1 to 2 milligrams that we're used to if they have really experienced a massive exposure. Additionally, these patients can develop seizures, and so we're going to want to use benzodiazepines to treat them. There's not too much different about the dosing compared to what you would normally do for seizures. 5 to 10 milligrams or something like diazepam or midazolam is reasonable. 2 to 4 milligrams of lorazepam is reasonable. Just kind of whatever you would normally do for seizures in another setting. And then finally, something worth talking about is pralidoxime, which is specific to the organophosphate insecticides or the chemical warfare agents. So we mentioned how these nerve agents work by binding to acetylcholinesterase. But something unique for organophosphates, whether it's the insecticide or the chemical warfare agent, is they undergo this process called aging, where they go from a reversible bond to the acetylcholinesterase to a permanent bond. And so once that permanent bond has happened, that patient is going to be stuck with a deficiency of acetylcholinesterase till they can regenerate that enzyme over the course of days to weeks. And so ideally, we want to give these patients pralidoxime to prevent that aging process. And it may have some additional benefits of just binding the nerve agents directly. But the main sort of purpose of administering is to prevent that aging process and prevent that bond to acetylcholinesterase from becoming permanent. The time to aging is going to vary by agent. Some of these agents will age within minutes, in which case it's going to be pretty difficult to get pralidoxime to the patient fast enough to prevent it. But some of these agents age over the course of hours or days where we have plenty of time to intervene. In general, if in doubt, go ahead and give the pralidoxime and we can kind of sort it out after the fact. Initial doses, just as a reference, is 30 milligrams per kilogram or up to 2 grams in an IV in an adult given IV, and then an infusion of 10 milligrams per kilogram per hour. Another thing I wanted to briefly mention is there are IM autoinjector kits available for the delivery of atropine and pralidoxime. Typically, the kits are designed to give 2 milligrams of atropine and 600 milligrams of pralidoxime. And they're designed to give 1, 2, or 3 kits based on whether the patient's presenting with mild, moderate, or severe toxicity from the nerve agents. Historically, the kits came with a separate pralidoxime and atropine injector, and newer kits have them both put into the same auto injector. And then last, the major category I want to talk about is asphyxiants. There's a number of chemicals in this family, things as common as carbon dioxide, propane, and carbon monoxide, to somewhat rarer exposures such as azide, cyanide, and hydrogen sulfide. Some examples pictured here. We're all familiar with the exhaust from cars having high quantities of carbon dioxide, and then also potentially some carbon monoxide, depending on how well the catalytic converter is working. Additionally, in areas of volcanic activity, you can have gaseous emissions from the crust of the earth that contain hydrogen sulfide, or in areas where you have a lot of organic matter breaking down, such as manure pits or garbage dumps, you can have large quantities of hydrogen sulfide being created. Additionally, in terms of intentional acts of harm, famously in Chicago several decades ago, there was an outbreak of acetaminophen being tampered with and contaminated with cyanide, which resulted in the death of a number of patients. Ultimately, we break these asphyxiants apart into chemical asphyxiants and simple asphyxiants. The simple asphyxiants are things like carbon dioxide and propane that mostly just displace oxygen from the environment and asphyxiate the patient that way. Chemical asphyxiants interfere with the delivery of oxygen from the environment to the tissues. And we'll look at that a little bit more in this slide. So the easiest way to asphyxiate a patient would be simply to deprive them of oxygen. Colloquially, we use the term asphyxiant when we think about patients who have been strangled or choked. But if you just remove the oxygen from the environment by displacing from the air with carbon dioxide or some other gas, then you would essentially have the same effect where oxygen wouldn't make it to the hemoglobin and then wouldn't make it to the mitochondria to participate in energy generation through aerobic metabolism. But there's other steps in this pathway that we can intervene in and still asphyxiate the patient. So carbon monoxide can bind to hemoglobin and prevent oxygen from then being able to be delivered by hemoglobin. Agents like nitrites and nitrates can generate methemoglobinemia, which again prevents the hemoglobin from delivering oxygen. And then agents like hydrogen sulfide, cyanide can actually interfere with the utilization of oxygen at the cellular level and essentially have the same effect that we're no longer to generate energy using oxygen. In terms of how these patients present, the most severe presentation would be what we would call a knockdown gas. This is the patient who has intentionally harmed themselves in a vehicle by generating hydrogen sulfide gas, or the patient who has gone down into a sewer without appropriate respiratory protection and succumbed to hydrogen sulfide gas. Or potentially, often what we'll see is a patient who goes down in a sewer or in a manure field because of hydrogen sulfide, and then rescuers attempt to go and intervene and themselves become victims. And that's just the rapid, that's just due to how rapidly these agents are interfering with oxygen delivery and oxygen utilization. In less severe cases, we're going to present more with shock and altered mental status. Excellent examples of this would be patients exposed to house fires who either from carbon monoxide or more concerningly from cyanide being generated from melting plastic will present with not just burn pathology, but also with altered mental status and shock due to their inability to use oxygen for energy generation. And then more mild cases will present with tachycardia and tachypnea as patients try to make up for the lack of oxygen utilization or oxygen delivery by trying to take more rapid breaths and more rapidly circulate their blood around. In terms of treatment for asphyxiants, decontamination is going to be one of the main interventions for these patients, most notably removing them from the scene, removing them from exposure to that agent. Additionally, we can try oxygen supplementation. That's going to have variable effects depending on the specific etiology of their asphyxiation. But there's a couple of specific agent-specific antidotes that are worth us discussing. Cyanide in particular, we can treat with a relatively new antidote, hydroxycobalamin. This is an agent we give over as 5 grams, given IV over 15 minutes, and then you can repeat it if you need to. And hydroxycobalamin will directly bind the cyanide and essentially becomes vitamin B12 in the blood, which can then be excreted. So very nice antidote that doesn't have a whole lot of adverse effects, though it can discolor the urine red and it can lead to a little bit of hypertension, but provides a nice solution to the problem of cyanide poisoning. There's pediatric dosing that's recommended. It's not in the FDA package insert, but certainly would be the recommendation if you had a pediatric patient exposed to cyanide. The older treatment before hydroxycobalamin for cyanide was a kit that contained amyl nitrite, sodium nitrite, and sodium thiosulfate. And there was some evidence that this might also be useful in hydrogen sulfide and other sulfide exposures. The idea behind these kits was that the amyl nitrite and the sodium nitrite would actually induce methemoglobinemia, which then acted to bind up the cyanide. And so while methemoglobinemia is not a great problem to have, it allows the cyanide to be pulled out of the mitochondria, out of the cells, and then bound up into the hemoglobin and traded kind of a more severe problem for a more mild problem. And sodium thiosulfate would work to help metabolize the cyanide and eliminate it from the body. The first line treatment ideally is hydroxycobalamin in this day and age, just because it's a more straightforward antidote with fewer risks. There's some nuance involved with using the nitrites and thiosulfate, and I would recommend involving a toxicologist or poison center if you're going down that route. One other specific treatment worth mentioning is if we have an agent like a nitrite or a nitrate that induces methemoglobinemia, and the methemoglobinemia is actually a problem and not something we're using to try to treat a more serious problem, and we can reverse that using methylene blue. This is given over as 1 to 2 milligrams per kilogram, given over 5 minutes, and we can repeat it after 30 minutes. And it just reduces the methemoglobinemia back to normal hemoglobin and allows it to resume its normal function. All right, with that, I will turn it over to Kathy, and I appreciate y'all's time.
Thank you, Dr. Wilson. Just going to share my screen. Okay, can you see my screen okay?
Yeah, Kathy, it's not showing your presenter view. So I don't know if you need to switch it there. There
That
you
better?
go. Yep.
Okay, great. Thank you. All right. Good afternoon, everyone, and thank you for attending our webinar. I'm going to switch gears after Dr. Wilson's excellent overview of the agents and talk a little bit more about the resources that would potentially be available. So I'm going to start with our chemical specialty team that we have for Region 7. Primary mission is to assist in the medical management of chemical emergencies throughout our region. Anytime that information is needed, requirements exceed capabilities of the local. Here would be some examples of chemical emergencies that, you know, if you have something like this that occurs in your community, you probably are thinking about, you know, maybe you need some additional assistance. And Dr. Wilson did a good job of giving a number of examples. But really, anything where you feel you need some some expertise on the medical management of chemical or other hazardous materials exposures, please keep us in mind. And I know that we have people from outside of this region. So I will definitely talk more in general too about poison centers and the wonderful information that every poison center can provide. Specifically in our region, we have 4 states, and we're blessed to have 4 poison centers. So we have the Iowa Poison Center, which is located in Sioux City. We have the Missouri Center, which is in St. Louis. The Kansas Center is located in Kansas City, Kansas. And then the Nebraska Center is located in Omaha. And so we've really come together, our poison centers, and work together to develop this team. And all of our centers have board certified medical toxicologists. Some also have clinical toxicologists. We all have certified specialists in poison information. They're all RNs, pharmacists, and then so our focus really is less on the decontamination side of it. We would definitely be looking at the assistance from all the awesome hazmat teams that are available in our areas. The civil support team, I'll talk a little bit more about that. Those are excellent supplements to what our team really is looking at. Team of poison center experts is more than medical management. So how would our team be activated? Very simple. You make one phone call, and it happens to be the National Poison Center, the Poison Help 800 number. And so the way that looks, the way the number works is you call that from anywhere in the United States, and you'll be routed to the poison center who's designated to serve your state. And so if you call this 800 number from Iowa, for instance, you'll get the Iowa Poison Center in Sioux City. And I think you get how it works. But basically, it's making one phone call, and then the poison center will be able to immediately help you with advice and treatment recommendations to help you manage the poisoning exposure, the chemical exposure. But again, if we need to get our team assembled and we need to take more of a regional approach, then we get the ball rolling from there. So many of you, I think, are familiar with the 800 number. I just wanted to point out, you may not have seen this Poison Help logo before. It happens to be brand new. So it's just an updated logo, which I think is kind of cute. So how do we operate? Really, there are three main modes that we can utilize, or we can actually combine. So when you call, as I mentioned, immediate telephone advice, and that may be all that's needed, is we're providing the advice via telephone. If we need to escalate that up and get a Zoom or other technology involved, then we can do that. With additional advice, with training, our toxicologists can work directly with providers if need be on management. And then if it's a situation where we really feel that we need boots on the ground, we need experts at the scene, then we can arrange that. We haven't done that yet, but certainly it's something that we could do. And that way we could do more hands-on assistance with patient and event management, and or provide some just-in-time training if this would be a large event where we would need to do that. And more specifically then, how can our team help? One of the things that we can do when we receive a call is, you may not know what hazard materials have been involved, but we will be taking as much of a history as we can get. So if you know the history or the circumstances surrounding the exposure, or the symptoms that victims are presenting with, that often can help us to identify what hazardous materials may be involved, which would be very important to think about going forward with management. Then what we will do is we will assess the potential toxicity of the agent or agents involved, and identify are there some immediate dangers that we need to think about in terms of scene safety, for instance, and even healthcare providers in self-protection. We will triage. So based again upon the patient status, the chemicals we think that are involved, we will help guide the providers on, whether or not even public callers, do you need to be seen? Can we manage this at home? Do we need to get EMS involved? So we do triage every time we're called to the poison center. We certainly will guide on decontamination, and although, as I mentioned, we would really rely on hazmat teams and others to assist with that. Certainly toxicity information and treatment recommendations. We're going to notify the hospitals if we're aware that victims are going to specific hospitals. We will make phone calls and let them know. And then for those victims, we could really customize our recommendations, provide some patient-specific treatment advice and follow up on those patients. However, we would in a hazardous materials or larger scale chemical incident, we would want to make sure that all area hospitals are aware of what's happening, even if they haven't received any patients. They may, so they need a heads up on that. Public health certainly would need a heads up as well. And so what we do is we will send out, we'll blast it out there, whether it be, we still, at least in Nebraska, our hospitals still use old-fashioned fax machine. They love to just have it going because they know we're going to quickly fax things over to them, and it's simple and quick. So we'll fax some information out. We also have email lists where we will get that out. And if it's a chemical that we happen to already have a clinical guideline on, which all of our poison centers have a number of fairly detailed clinical guidelines, we would also include that, attach it to the email, fax that out again, so that everybody has a heads up. So cyanide would be an example. We have a clinical guideline, we would get that out. If it's a more obscure chemical, something that's not as common, then we would create something. We would go ahead and put something together with detailed clinical information based upon what's happening. Part of our treatment recommendations certainly would be to provide antidote dosing and administration info. And then even we know where the antidotes are available in our area, and we can assist with transferring those. And then again, depending on the location, depending on the incident, we also may be able to provide some bedside consultation and in-person support as well. And then just additional chemical exposure management resources to think about that I want to touch on. One, I think I've probably hit the point home here, but all poison centers, we have 55 poison centers in the United States. Again, the 800 number is listed there. If you call your poison center, they are going to be able to do most of what we have done that we've put together through our team. All poison centers are staffed with nationally certified toxicologists. They have nurse and pharmacist specialists available 24/7. And their goal and role is to provide immediate assistance and guidance on the medical management of any type of poisoning, including chemical exposures. And so that's something that we as poison center folks, we do that day in and day out. And all poison centers also do track the statewide antidote availability. Like our centers, they put out surveys and they make sure that they know where the antidotes are located, and also can assist with the location. So please keep that in mind, and know that poison centers are just an excellent resource for you related to the chemical exposures. I'm going to talk a little bit more. I've got some additional slides here to discuss some other medication stockpile resources, specifically for chemicals. I'll show you a reference guide, talk a little bit about the civil support teams, and then put a little plug in for some of our upcoming courses. So I chose to include this and highlight it. I understand that it's might be a little bit more focused just in Omaha or perhaps Nebraska, but I want to say from the outset that we do share. And so we have our Omaha Metropolitan Healthcare Coalition Pharmacy Work Group, got started way back in 1999. I've been fortunate to be able to share the group since its inception. And we have put together a team we have hospital and community pharmacists, we have paramedics, public health folks, poison center folks, who have regularly worked on assessing pharmaceutical availability and then what would the needs be during disasters. And this could be, it's primarily, we focus on the CBRN, the chemical, biological, radiological, and nuclear, but certainly we have, if I had more time, I could tell you many stories about other types of public health emergencies and other disasters that we have assisted in providing pharmaceuticals for. So we have purchased some, we've got some state Homeland Security grant funding and have been able to make some purchases. And when they've expired, we've been able to update those depending on available funding and also, our assessment of needs at the time. We have forward placed these, some of them in rescue squads. The cyano kit, for instance, that Dr. Wilson mentioned, and it's pictured there in the lower right corner. We do have those on Omaha area rescue squads, the cyanide exposures are relatively rare, but the smoke inhalation from fire exposures, especially within the last couple of months here, have been fairly frequent, and we have utilized a number of those. So I think the point here is that our stockpiled meds can and have been shared throughout the region. And so, that's something to keep in mind, particularly if you are in Region 7, if you have a need for certain, and again, if you've involved our team, our chemical team, then we would probably already be aware of the situation and what you might have need for. And we might be able to share and get some of these meds to you sooner than going through, for instance, the pharmaceutical supplier. Another thing to I guess, piece of advice would be, if you're planning, would be just to know the location of your other caches. Another example is we have representatives on our coalition work group from both VA Medical Center and Offutt from their pharmacies. And while they haven't been able to share specifically what all they do have federal stockpiles. And it is something where they have told us That is, they would be able to, depending on the situation and what their needs would be, they would certainly be willing to share in emergencies if need be. So I've got all the contact information and I can call on them if need be. And then other types of public health emergencies, as I alluded to, we've had other instances where we have, maybe they're less traditional than we thought we would need to be supplying, but we had a large scale flood in the Omaha, parts of Nebraska, I know parts of Iowa, and I believe even the surrounding states. Our large flood in 2019, we had many calls to our poison center for tetanus vaccines, and we were able to make those arrangements and get, with the assistance of the State Patrol and others, get those where they needed to go. And so how do you request these resources? You call us at the Nebraska Regional Poison Center. We are the 24/7 contact. If you call from Nebraska, as I mentioned how the phone line works, if you call the national 800 number from Nebraska, it should route to our center. If you call another poison center and you mention you need Nebraska, they know how to get a hold of us too, but our local number is also included there as well. If you're wondering what those blue pills in the middle are of the slide, that is Prussian blue, used for some radioactive cesium and thallium, and it is something that we happen to have stockpiled. So our pharmacy work group and our poison center kind of collaborated and put together this reference guide. So on the front side is just an overview, as you can see, the various categories of CBRN agents. And, it is a high level overview. We have received quite a bit of positive feedback over the years on this. We do review it, the document, through our poison center and pharmacy work group, at least every 1 to 2 years, and then we make updates as needed. This is available on our nebraskapoison.com, so our poison center website, for you to utilize, and feel free to do so. On the back side then is a quick reference guide that, as you can see, there are a number of pharmaceuticals listed based on those categories on the other side. And I would stress, though, again, these are dose specific. They're probably helpful, but if you have a specific patient, contact your poison center, because then, as I mentioned already, we can definitely customize the treatment recommendations to the specific patient. Chem packs are another resource that we've been pretty involved with the request process. So they are part of the Strategic National Stockpile, they're forward placed, which is really awesome. Rather than having to wait for them to come, where they would be needed right away. So all states have chem pack containers in their state. The states determine where they want to locate those. And they really are awesome in the ability to, if we would have a nerve agent event or an organophosphate insecticide, as Dr. Wilson talked about, many of these are there. They're available in those containers. There's 2 types of containers. These are some chem packs that we received into Nebraska, but the one on the right is hospital. That one contains both auto injectors and vials, but primarily vials for hospital use. The EMS container on the left is primarily auto injectors, but it does have some vials as well. The hospital chem pack has enough medications to treat approximately 1,000 victims, whereas the EMS chem pack is 454 victims. So it has fewer resources. I think when they were putting it together, my understanding is those auto injectors got very, very expensive, which I know they did, because we purchased some of those. And so they're a little costlier to set up the EMS ones, but they are secure. They're temperature monitored. If you open one up, CDC knows about it, bells and whistles go off, and there's a whole process. So, but they are there and should be utilized if need be. And so how to request these? That will vary from state to state, even within our region. In Iowa, there's a 24/7 duty officer, or there's a newer SNS. The other longstanding person, Steve Mercer, had retired recently. So Brent Spears, the new SNS coordinator. Kansas has a all hazard emergency notification line. Missouri. I had a chance, Katie Beasley, I got a chance to correspond with her last week. And so her contact information is there, and she sent me some great information about their SNS and ChemPAC program. In Nebraska, again, it's a little unique. I think I do know of a few other poison centers where you call your poison center and you can request a ChemPAC. We're one of those. So you can call us 24/7. We'll immediately be able to help you with management of the exposure. And we also have the contacts, and we can get the ball rolling on the request process and notifying public health and emergency management, or the alternate number there for the public health response line, which incidentally, if you call that, you're also getting our staff at the poison center. So, if we have, again, if you're in Nebraska specifically, and you would call us and tell us about a nerve agent exposure, and wonder about resources, because we have local resources, it may not be necessary to open a ChemPAC. At least initially, we would be able to make arrangements to get you some of the other resources that we have stockpiled. But again, we share. So if this happens in other areas, we are more than willing to share, and have done so. And we know from experience that the State Patrol has been very helpful and very quick in getting resources to where they need to go. And then we have the civil support teams. They are National Guard assets. They are, so their deployment has to be requested by the governor. We have one in every state in the United States, including the 4 in our region. So there are the names listed there. They have an amazing amount of expertise. I had the opportunity a couple of years ago to go visit our 72nd CST, which is located in Lincoln, Nebraska. And I got to see, the equipment they have, their mobile lab, their communications vehicle, find out the training that they have available, and it's quite impressive. So I guess that's something to always keep in mind, and get to know the people on your team if you have the opportunity, because they're really awesome. And then lastly, I just want to plug, put a little bit of an advertisement, I guess, in for our advanced hazmat life support courses. We've been fortunate through this, through our Region 7 project, to have some funding. So the last couple of years, we have held courses in Omaha, which is kind of central to our region. But this year, our goal is to reach out to every state and have one course in each of our 4 states that we serve in our region. And so we have coming up in April, we have a course out near Dr. Wilson in Coralville, Iowa City area. And then we have one scheduled for Kearney, which will be our Nebraska location in July. And then for Kansas and Missouri, we are still looking for locations. So if you're in Kansas or Missouri, if you would like us to come, we bring our certified instructors. So it's our medical toxicologists or medical directors. It's certified specialists. It's primarily poison center people then who would come and present a 2-day detailed provider course. If you liked Dr. Wilson's presentation, you'll love this type of course, because it's very in-depth, detailed. It covers in more detail even some of the topics and more that he covered for chemical. It also covers radiological to a lesser extent, and some biological at the end of the 2-day course. And it really is geared towards the medical management of patients. And so it's really for providers. It's paramedics, EMTs, it's physicians, nurses, pharmacists, respiratory therapists. And at the end of the 2nd day, you take an exam and you get a verification for the course. If you want to become an instructor, you take an additional half day. But back to Kansas, Missouri, yes, please email us if you know of a location you think that would be good. We bring everything in, and including the funding. And you can go to the AHLS website right now if you're interested in the Iowa course. We do still have some tuition scholarships available, but it's filling up. It's going first come, first serve. I would say within the next week or 2, the Kearney location should be up as well. And it looks like my time is up. pretty good timing there. So if you have any questions, please reach out to either Dr. Wilson or myself. And appreciate everyone's time and attention. Back to you, Lauren.
Yeah, great. Thank you, Kathy. Thanks, Dr. Wilson. Lots of great questions that we have here. So we'll start off. Someone asked, how does the 1-800 number handle someone in Iowa but has a mobile number from California? So I think what we're asking, is it based on your location, kind of like how the 911 centers are?
Okay, I can take that one. Yes, it really is from, if you have a mobile number and say you're in Iowa, but you're calling from Iowa, hopefully, I will say, hopefully it will work and it will go to the Iowa Center. It may, they'll go back to California. There are a few glitches in the system where they are working on improving it, but because we have a network of poison centers that work so closely with each other, if you would happen to reach California or the state that you didn't intend to reach, we transfer calls back to each other all of the time. So we could still, every poison center can still get you where you need to go.
Great, thank you, Kathy. Another question here, this one might be for Dr. Wilson. So it looks like we have a attendee today from the UK. He's asking, how should we use or equip our hospitals to treat these patients without decontaminating the whole resuscitation room?
I would say that in most systems, there's kind of a segregation of responsibility. And usually the EMS system ends up doing the brunt of the decontamination. And ideally, by the time they make it to the hospital, they've at least gone through that initial decontamination. I think the challenge ends up being when patients don't go through the EMS system, when a lot of the walking wounded or the more mildly exposed end up making their own way to the emergency department. So, I think the first challenge is making sure that we identify those patients and ideally catch them before they make it into the hospital. Because I agree, decontaminating an entire resuscitation room would be a tremendous burden. And it would be a lot better if we taught them before they entered the hospital. Some will probably slip through it, and I don't know that there's a good answer. I think once they've made it in, you're going to be stuck doing a more thorough clean of that room. But ideally, working with your disaster response people, that includes not just the physicians and the nurses and the techs, but also the security teams, the administrators, the people who can identify that there's a mass casualty or some sort of exposure going on and quickly set up a screening process so that they're decontaminated outside the hospital walls, often in some sort of pre-planned outdoor shower or other resource. So the short answer is that a lot of planning to keep them from making it to the resuscitation room before they've been decontaminated. Does that answer your question?
Thanks, Dr. Wilson. We'll go ahead and send out Dr. Wilson and Kathy's emails as well at the end so we can follow up with additional questions. Let's see here. Kathy, I think this one would be for you. So we have someone in the chat wondering how they would be able to obtain cyano kits if their agency or facility isn't able to afford them.
That's an excellent question. It is, you definitely, do they say where they're located? Probably not. I would say contact your poison center, no matter where you're located. They can at least get going with assisting you. Poison centers have contacts with all of the hospitals, and they know the pharmacies. They know what the hospital's capabilities are. They've already surveyed the hospitals. So the center would be able to tell you which hospital closest to you would have a cyano kit, or they should be able to connect you with a pharmacist who would be able to order one if need be. I think that would probably be the best way to do it. You can always reach out to your poison center. They would have the best knowledge of what would be available in your area.
Great, thanks, Kathy. Let's see here. Dr. Wilson, should the chlorine inhalation patients be initiated on nebulized sodium bicarb in the field or delayed until the hospital?
I don't know that there's a 100% right answer to that. I would probably delay it to they're in the hospital, just because pre-hospital you probably have other interventions that are going to be more important, either kind of managing their oxygenation, getting them an albuterol or other bronchodilator. I think that's probably a treatment that you could delay to the hospital, since the efficacy is a little bit more questioned in the literature. Certainly, if that's your only patient and you're just kind of staring at them for an hour-long ambulance ride because it happened out somewhere very remote from a healthcare facility, then it's a reasonable intervention. I just wouldn't prioritize it over other interventions, and I wouldn't give up other resources to carry sodium bicarbonate for the purposes of treating a chlorine gas exposure.
Great, thank you. We probably have time here for one more question. So there is some comments here that we have that the HLS for radiological incidents and terrorism is a great course as well. So Kathy, we might have to put that on our list and take a look at that one. So who is responsible for paying for the services and medications? Would it be the fire rescue response agency, the hospital, or the patient?
Okay, I can take that. If it's for the medications that we've stockpiled, in general, those that we supply on the rescue squads are really the hospitals. Those that are grant funded, they're not charged to the patient, but we do ask the hospitals to replace them if they can. With the rescue squads, certainly they're at least in our area, they're not able to do that. So we're fortunate we have some funds, and our funding is through state Homeland Security that we've been able to stockpile those. In general, if it's a hospital stockpile, then they can charge that. They would charge that to the patient.
Thanks, Kathy. And Kathy, are the cyanide kits part of the chem packs or no?
Excellent question, and no, they are not part of the chem pack.
Great, thank you.
I guess I would add, because there's a number of questions about the cyano kits. If I do have a point of contact, if you're interested in purchasing cyano kits or stockpiling, please reach out to me. I have a contact person that I could share. And I will tell you that they are pricey. One cyano kit is, well, we just reordered, I think it was $923 for one. So they are a bit pricey.
Thanks, Kathy. One more quick question here. Dr. Wilson, can you speak to the use of the Zolmasmo Rainbow CO device for diagnosis and treatment?
Yeah, absolutely. So I guess to get everyone on the same page, there are some pulse oximeters that are able to detect carbon monoxide rather than just SpO2. I don't know that they're super widely available yet, but certainly they're out there. And I think if you have it, it's a great tool and you might as well use it. If you don't, then you can always put patients on oxygen and treat them presumptively as if they were carbon monoxide exposure until you prove otherwise. Just trying to imagine the situation where it would be most useful. I could see in a mass casualty event, maybe using it for your initial triaging of deciding, if you only have 3 oxygen tanks, what 3 patients are going to get that oxygen, or who's going to be transported to the hospital first. But yeah, I think if it's a tool at your disposal, it's certainly a useful one.
Great. Thank you. And that, I think, concludes our webinar for today. We do apologize. We're aware of some issues with the CE link, so we'll follow up with our continuing education department and get that sent out to everyone. We appreciate everyone attending today. The webinar will be hosted on our website within 3 to 5 business days, and you can watch the recording there. Continuing education can only be obtained for live viewing of today's webinar. So with any questions, please reach out to us, R7DHRE at unmc.edu. You can check us out on LinkedIn, Facebook, and on the web. Thanks, everyone.
Thank you.
Thank you.